గుడ్ ఈవినింగ్ ఆల్. నేను మీ నాగజ్యోతిని, పేషెంట్ల ఆశా జ్యోతిని, మా ఆయన జీవన జ్యోతిని. We have come together in this hot hitting evening to learn and gain some clinical wisdom. This is our second webinar. మనము ఏమీ లేని నుంచి ప్రారంభించడం ఒక మొదటి మెట్టు అయితే, ఎక్కుతూనే ఉండాలి ఒక్కొక్క మెట్టు, విజయానికి లేదు చివరి మెట్టు. Menopause is an important stepping stone in the path of women's life. All of us try to age youthfully. Okay, to start this session, first I would like to invite President of AOGS, Dr. Aruna Madam, Managing Director of Snehalata Hospital, Anandapur. Welcome you, ma'am. Next, I invite Sandhya Madam రాలేదు కదా.
హలో మేడం.
నెక్స్ట్ ఐ ఇన్వైట్ సంధ్య మేడం రాలేదు కదా.
మేడం
పార్టిసిపెంట్స్ లో కనిపించట్లేదు. నెక్స్ట్ ఐ ఇన్వైట్ డాక్టర్ జ్యోతి సుచిత్ర మేడం టు ఇగ్నైట్ the light of the jyoti of awareness on this topic. I am happy to invite Dr. Sundari Madam, moderator of this session. Madam, enta busy ga unna webinars tho mana దీన్ని యాక్సెప్ట్ చేసి moderator గా ఉన్నందుకు thank you very much, madam. Thank you, madam. Then I would like to say welcome words to all our panel faculty, Dr. Mubintaz, Dr. Nivedita, Dr. Sweta.
Good evening, ma'am.
Dr. Hemantamani, Dr. Anusha from Hindupur,
Good evening, ma'am.
and Dr. Indira Priyadarshini.
Good evening, ma'am.
Welcome you all. Over to you, Jyoti Suchitra, madam.
Good evening, everybody. Thank you for joining us all. In the pursuit of this wisdom, knowledge can be gained everywhere, but wisdom can be gained from only some people. And we are here before all the elders of this August webinar, like ma'am, Sundari ma'am, Aruna ma'am, who are literally practicing the menopausal hormone therapy. The main intention was, like ma'am was telling, knowledge can be gained, but what the main need is how we are practicing this knowledge in our area, because the practitioner should all have a common idea of what we are going to do in our place, so that the patients will not be confused. If they go to one doctor, they will say something, and if they go to another doctor, they will have another thing. So common protocol, common guideline, so that will not be confusing the patient, can give best to the patient. That is one of the main idea for this local webinars, I feel. International webinars and national webinars can be done, but this local webinar, we think that we should be equipped to the knowledge, and we should cater to our population mainly. That is the main importance of this webinar. And we all know that soon we will be encountering many women who are in 40s, 50s and 60s, and who are very active, too active than the youngsters, because of the both experience and the energy levels they are having. So naturally they will be having some problems, medical problems, menopausal symptoms. So we need to be equipped to face them and give them correct advice and treatment. So here we are, so equipped with this webinar sessions. I think some 4 or 5 webinars have been planned. So we will listen to the panelists. And what madam has been saying is not just to give a lecture, but we will interact with our common cases which we encounter in our day-to-day life, not somewhere from international level, but Anantapur level. What are the common cases we encounter and how we try to treat it? Over to the panelists without taking much of my time. Thank you. Missy, I think you can start with the moderator and the panelist, the discussion.
Yes. Sundari madam, can you share your screen, madam?
I have shared.
Session, madam.
You can see the screen.
Yes, madam.
You can see.
Yes. Yes,
Is it
madam.
visible? Okay. Thank you, the president, Dr. Aruna, and of course the very active. One minute. Something is happening. Okay. Is it seen? The screen is seen for you?
Yes, madam, it is visible.
Some problem here. Okay. Sorry for that. And Dr. Aruna and Vinutana and Nagajyoti and Dr. Jyoti Suchitra and Dr. Sandhya. Thank you very much for involving me into your sessions. I'm learning a lot because you have given me this task to do it. And all the panelists, I see all of them are very young and enthusiastic panelists. I little hesitate to talk to all the youngsters probably. They will be telling me much more than what I say, okay? So we'll start the panel discussion on today's topic is menopause hormone therapy. I think all of you know. See, until recently, I tell you, I'm in my 70s. I never had the opportunity to think of MHT or I have taken MHT because only I started practicing MHT after much, much later because it's only maybe 15, 20 years where the momentum for understanding the menopause and understanding the menopause hormone therapy has come up. Okay, this is because we have a lot of menopausal women. Now the women live long. So one third of our life we are living in menopause. So we need to know their problems and the cure or a treatment for it. We need to know. That's the way the menopause and the menopause hormone therapy has come to limelight. Menopause and MHT are topics of maximum. If you take any medical condition, you just think of any condition, medical or OBGYN conditions, the most controversial topic is menopause. There is no definite answer, yes or no, for any of these menopause problems to treat with. Especially MHT, if you take, it is everywhere there is a question. So we need to understand that. It's not very easy to treat. Yes, I'll give or I don't give is not the question. That's why our patients will become very confused. Our women, I don't say patients, our women get confused because each one has got their own way to interpret this and advise this. I think this webinar should give us all an insight into this. And all of us must be speaking or singing the same song when our patients approach to us with the menopausal problems. That's an idea of doing this case-based study. Okay, not every woman requires hormones, we need to know that, but women benefit greatly if there is a judicious and timely use of hormone therapy. So as I told you, and it is not forever medication. It's only for a short time with a judicious use has got a maximum benefit. With that introductory note, we'll start the panel discussion. Please understand. And these are my young and energetic panelists. Thanks for all of them to join and make me become more younger, feel younger. So we will be discussing a case-based study here. In that, we'll be discussing benefits and risk of MHT, timing and duration of the therapy, individual risks and recommendations and contraindications for MHT. This is all we are going to cover if the time permits for us to do it. Okay. Now, I think the questions, I don't ask anyone in particular. Probably you can take up the questions as you want. Is it okay for you people? Okay? Yes?
Yes, ma'am.
Okay.
Yes, ma'am.
So you can start taking each one of you, whoever wants to take the question you want. Unless, otherwise I have to ask the particular names I have to call out. I don't want that. A 45-year-old lady wants to know whether she can start MHT before she attains menopause. She has slightly irregular periods with no other symptoms. She's an educated lady. She heard a lot about menopause and all. So she wants to know whether she can start. Her mother had menopause at 47th year of her age. Now she's 45. Yes. Who will take it up? Youngest of the lot.
Anusha will be taking.
Anusha? Okay, Anusha. Yes, Anusha. You are the opening bus woman.
Yeah. Ma'am, good evening.
Good evening.
Good evening, ma'am. Thank you so much for the opportunity.
Not
Ma'am,
me, you
usually
thank your
menopausal
own team. I'm
yeah,
only one
for the
like you.
whole team.
Yeah, go ahead.
Ma'am, menopausal hormone therapy is usually the therapy which we give to treat the symptoms which occurs because of the lack of the estrogen that occurs in menopause. So
Okay.
this is not the treatment that we give prophylactically. This is the treatment we use to treat the symptoms of the menopause. It is not the treatment for all, and it is not the mm, it is not treatment for all, ma'am. It is tailor-made treatment. Those who have the symptoms of menopause.
Very good. Very clearly, she said to us, very clear statements in the beginning itself. So it is not a prophylaxis, but it's only for the treatment of symptoms. Symptoms vary. Different women will have different degree of symptoms. So we'll go through that. Okay. 50-year-old woman heard of MHT. She wants to know more about MHT. She has come to you for a counseling rather. Somebody, my neighbor is taking, madam. She said that she's taking some hormone therapy, I believe. She went to Bangalore and got it done from somebody. So she was just telling as though she has done a great job. So this lady comes to you. She's your patient. She comes to you having many questions about this MHT. Her questions are who should take and who should not take, and if we are taking, what is the drugs available and how do I take? These are the questions. Now Nivedita will take it up this, or anybody. Just you can start off. Who is going to talk about?
I think
Who is going to take it up?
Anusha is going to take this question also, madam.
Huh?
Anusha is going to
Shall I take, ma'am?
question also, madam.
Anusha.
Yes, madam.
Yeah, ma'am. Shall I?
Okay. You have decided like that. It's okay.
Yes, ma'am.
I thought every one of you go around. I thought. Anyway, it's okay. Whoever wants. Okay, I don't call the names. But please start off immediately so that we'll save some time.
Okay, madam.
Okay.
Ma'am, usually,
Anusha said to us, not everybody, madam, only women who have symptoms, she said in her opening statement. So now let's ask her, what is that you mean by not every woman and who are the women who are going to advise this therapy? Okay, Anusha, go ahead now.
Ma'am, we are going to advise menopausal hormone therapy for a postmenopausal woman or a woman who is in early menopause, that is less than 10 years of menopause, and who is having symptoms like severe vasomotor symptoms and whose vasomotor symptoms are not elevated by lifestyle modifications or any other drugs like vitamin E or primrose or any other combination if we give, if the symptoms are not elevated, vasomotor symptoms and severe vaginal atrophy, and for severe if she's having symptoms of severe osteoporosis, and if she's having any sleep disorders or mood disorders or any sexual dysfunction, like this kind of patients, we advise menopausal hormone therapy.
See, not only the menopause, Anusha, even in
Yes, ma'am.
menopause
In case of premature ovarian, in case of patients like who has surgical menopause and patients who is having premature ovarian insufficiency patients also, we advise menopausal hormone therapy.
We don't talk about premature menopause and the POI because they have to have hormone therapy. There's no question of yes or no for them, especially POI, premature ovarian insufficiency. We have to treat them with hormones. There is no doubt universally it is accepted. When it comes to the natural menopause, and we can start at the menopause transition. See, when they are in the transition, I think last time we have seen the definitions for all that. In the last webinar, I think we spoke about the definitions of all these terminologies. We don't go back for that. Most important is menopause transition. These vasomotor symptoms are pretty high for them. So that's a time if we give them, their quality of life will improve. And they are not, it is not contraindicated for them because they are not yet attained menopause. That's the time we have to catch them and give them. As you said, yes, menopause, you told the criteria when to give. Definitely after 60 years, any woman comes and asks for menopausal therapy, you please say no, gently say no. But if she wants, still we have to say it's a shared decision. We have to explain to her all the risks and all. If she still wants to try, yes, we have to give other close surveillance. Okay, that's it. Okay, this is the way where we need to give. This is the time 40 to 50 menopausal transition. They have all these symptoms, what you beautifully explained, all the sleep disorders, mood changes, everything. They need here more. Now, as they come early menopause, they may start having these symptoms. Yes, there also they have to cover. Then it gets overlapped when she passes to the 60, these things. When we have covered her with this here and here with the hormone therapy, these things will be much less for her. That's what we have to understand. If you want to start here when she has, it is of no use. Plus, it may not be indicated also. So, where we have to start from here, it is ideal. But when she comes to this transition or just a menopause, when she has these symptoms, when you start MHT for this, these problems to certain extents will be taken care of. That's what we have to think of. Okay. Now, contraindications, any contraindications?
Yes, ma'am. Actually, for starting this menopausal,
Is there any absolute contraindication?
yes, ma'am. Endometrial cancer, and if she's having any history of CA breast, it is absolute contraindication. In case of in case of any liver problems, also it is contraindicated. Why? Because all the drug we give is metabolized through the liver, ma'am. And
Okay.
for starting a menopausal hormone therapy, that there is some guidelines in Indian Menopausal Society. That is right age, right drug, right dose, and right mode of administration.
Route, right
So we have
route.
to see all right route of administration. So before starting, there is some baseline investigation of the patient where we have to
We'll
see,
come to that.
and we
We'll
have
come
to
to
take
that.
it back.
The investigations and all
Yeah.
will come. So the absolute
There are
contraindication
some contraindications.
is the acute liver disease is a
There are some
contraindication.
contraindications.
Yes, ma. Go ahead. You wanted to say
CA
something?
endometrium, CA breast, liver disease. Yes, ma'am. If there is any history of any thromboembolic disorders, like if she's having previous history of any thromboembolic conditions, there we will not give any. She's having any history of psychological problems also, we'll evaluate whether to give or not.
Oh, good. So
Like
in this, among
Alzheimer's,
all
we
these
have
things what
to.
she has narrated, breast cancer and endometrial cancer, though we say no, but say except the clear cell carcinoma of the endometrium, other can, especially endometrioid endometrial cancer, after the treatment, you can start if she has got menopausal symptoms, you can give one is local estrogen if she has genitourinary. And after 3 years of her endometrial cancer treatment, you can start, but when you are giving here, you may have to give both hormones, estrogen and progesterone. Breast cancer also now they say that very young women are getting breast cancer. So when you remove, they are ER positive, ER positive, ovaries have been sacrificed. In that people also with a very, very shared decision, probably there's a small role to bring down the symptoms. That's all. That's why they said the absolute, but absolute contraindication, as you said, is the liver disease. And this is one thing I want to bring it to all your notice is non-alcoholic fatty liver disease. If you read, I mean, if you see any scan done for any woman nowadays, fatty liver. And a few people here will give the grading of the fatty liver, but I don't know in Anantapur whether they give grading. The fatty liver, anything more than grade 2, I think we have to be very cautious for giving hormone therapy for those women. And you have to advise them to reduce the weight and reduce and revert. See, up to stage 2 of the fatty liver, it will be reversible. After that, it is not reversible, and they are going in for liver failures, these women. So we are not concentrating on fatty liver. If you read the liver, first thing is about the liver, the fatty infiltration of the liver, and your conclusion they give fatty liver. Grading they may not give. Please remember when you have fatty liver, you have to explain to them and probably not be able to very boldly give for them also this hormone therapy. Wonderful. Okay. Now, what are the drugs used and the routes of available for delivering this MHT?
There are we have estrogen, either estrogen alone or a combination of estrogen plus progesterone. We have
Yes.
selective estrogen receptor modulators like
Yes.
raloxifene, and we have gonadotropins like tibolone.
Yes. And estrogen can be, that's one advantage with estrogen is either it could be local or systemic. Is it not?
Yes,
Local,
ma'am.
you have pessaries, rings. We don't have in India the vaginal pessaries of estrogen, progesterone, even combination therapies, they have rings and pessaries. Of course, we have the cream and we have the systemic transdermal patches and implants are very much available even in India. Good, ma'am. Okay. What are the adverse effects and risks of MHT? Any one of you? Or it's only Anusha has to be going on? Anyway, adverse effects of hormone therapy. We must know that when we are counseling the patient, all this we have to know. Anyone is answering?
Yeah, ma'am.
They may cause nausea,
please.
ma'am. And ma'am,
Yes.
can I, ma'am?
Yeah, please.
Yeah. So they may cause nausea and also bloating, ma'am. And the women may complain of weight gain and fluid retention also. Sometimes there may be breakthrough bleeding, ma'am. And the
Yeah.
woman may complain of breast tenderness and there is a chance of getting breast cancer and also endometrial cancer.
Yes.
And there may be episodes of thromboembolism events also.
Yes.
And biliary pathology also, that means there may be jaundice and liver pathology also noted when we take MHT.
So we have to, when a prolonged use is there, they are more prone for breast and endometrial cancers. We have to explain to them. The moment you say that, even in Bangalore city, women say, I don't want, madam. The moment you say more than 5 years, if you take, you may have slightly increased risk. Even I mentioned, they say, no, madam, I don't want. So that is the fear people do have it. Okay, these are all the things we need to explain to the patient, but in a way where they can accept it when they are in need of it. Okay. Now, the next question is, the scenario is 52 years, attained menopause 1 year back. She has no menopausal symptoms, luckily. She has no comorbidities, but her BMI is only 25. Wants to know whether she needs MHT. Now, how do you categorize woman for treatment purpose? Now she has absolutely no symptoms. Anusha told us that whenever symptomatic women we have to give. Now here is a lady, she attained menopause, she has no symptoms. Now what should we do? She comes and asks you a genuine question. Do I need, madam? What's your answer for her? How do you divide them?
Ma'am, to give management for a menopausal lady, we have to group them, ma'am, with symptoms and without symptoms.
Yes.
And
Now she
in our
comes to
case,
category of without symptoms.
yes, ma'am. In our case scenario, she has no comorbidities and she has no symptoms. But here one is age, that is 52 years.
Yeah.
And one mild risk factor, that is she is under overweight. BMI is 25 kg per meter square.
Okay.
Now this woman comes under a woman without the menopausal symptoms, ma'am. So when there is no menopausal symptoms, we have to start initiating the prevention care and promoting care. But anyway, the woman come to us and she is asking, so I want to evaluate that her history and everything if she needs MHT.
Okay.
Through history, I want to evaluate, ma'am. After
You
that,
want
I
to
will
evaluate whether she has no contraindications for MHT. If
Yes,
she
ma'am.
doesn't have any contraindication after evaluation, do you advise her, because she has no symptoms, do you advise her
No,
hormone
ma'am.
therapy or not? If so, why you advise her hormone therapy?
Okay. If there are no symptoms, I won't advise, ma'am. But after evaluation, if after 50 years there is a chance of osteopenia, chances are
Exactly.
also there,
So
ma'am.
for that you
So
may,
that's why I want to prevent osteoporosis. So that's why I will advise her MHT by doing DXA scan, ma'am.
Okay. Now other groups are women with symptoms. When she comes with the symptoms, of course, what will you do?
If she comes with symptoms, we will start MHT, ma'am, depending on her health diseases. If she's having any comorbidities, we will advise the risk. We will advise and we will counsel regarding the risks and benefits of the MHT.
Yes. So
And we will treat
spoke
the
about
disease.
risk and benefits already. Yes.
Yes, ma'am.
See,
And-
when if she has symptoms, she has to have. But one thing what we have to rule out in her is whether any contraindication
Yes,
is there at all. Is it not?
Yes, ma'am.
That comes with evaluation. Okay, after counseling, she wants to take MHT. Does she need any pre-therapy medical evaluation? That's what you have
We
been
have to
telling.
evaluate
Amisha
all
told.
histories.
Now, one of you can tell me what is in short, what is the medical evaluation we need to do for her?
So we need to evaluate her medical diseases, ma'am, like diabetes and hypertension and any cardiovascular problems, any previous deep vein thrombosis history and thyroid diseases,
Okay.
and also liver diseases, and any previous history of cancers like breast and ovary and endometrium, and any mental illnesses. And
Yes.
like osteoporosis and osteoarthritis, ma'am. So we will evaluate that. And her personal history also, already she told that there are no symptoms, but I want to take her diet history also. And I want to calculate her calcium diet calculation chart, like 300 mg per 1 glass of milk. So I want to take her diet history also, whether she is taking that proper calcium. Calcium 800 milligrams per day, a postmenopausal woman needs to take, a adult woman needs to take. So that's why I will calculate her calcium intake also. And at the same time, I will evaluate her any drug history. Is she on any medical drug? Is she taking any drugs?
Yeah.
And family history of CADs and also cerebrovascular diseases, and also family history of malignancies.
Wonderful. So, comprehensive history you have taken. Now, what are the investigations you would like to do for her?
So, investigations, like blood investigations.
What is the most important examinations you have to do in this lady?
Yeah. So first we will already we have given BMI in that case, ma'am. So first height and weight for any woman, and we have to calculate her BMI.
Yes.
And at the same time, blood pressure we need to measure.
Yes.
And we need to do the breast examination for any lumps which she did not know till now when she is coming to us. Yeah. And we will do her pelvic examination if needed. Pap smear also we have to take. And
It's
blood.
not if needed, not. You have to do
Okay.
pap smear because you know the hormone therapy can increase the chance of cervical cancer. You know that, no?
Yes, ma'am.
Whereas the endometrium and ovary, it's a protective. But for
Yes, ma'am.
of course, not in menopausal women for the ovary, but for the CS cervix, OC pills and the hormone therapy, they have little increased risk. So
we have to do pap smear.
You have to do a pap smear.
Yes, we have to do pap.
Yeah.
Yes, ma'am. We have to do a pap smear and we have to measure her waist circumference. So normally in adult women, it should be 80 centimeters.
Yeah.
If it is more than 88, they are more prone for comorbidities.
Okay.
Chronic diseases. And we need to do ultrasound pelvis.
Yeah.
And bone mineral density test. In India, women less than 5 years since menopause with any risk factors, or all women 5 years beyond her natural menopause. So this lady comes under women less than 5 years, ma'am. Yeah.
So she needn't have to get a DEXA done.
Yes, ma'am. And investigations like blood sugar and thyroid profile and lipid profile and LFT and RFT, ma'am, liver function test and renal function test.
And mammography has to be done.
Mammography, yes, ma'am. And coagulation profile also we need to do.
Routinely may not be if they have a family history of
thromboembolic events.
I had one girl, young girl who was on OC pills. Just 1 month she took OC pill and she came back with a deep vein thrombosis.
Okay.
So I remember very well, very young lady. Okay. So if we have this APLA syndromes, we are not regularly evaluating for APLA, but at least you take a history which is suggestive of these DVTs in the family or something. Then we may have to think of APLA and then go for the extended investigations. Otherwise, there is no need of routine coagulation profile. Good, very good. Okay, after thorough evaluation, she's found that she has no health problems. Luckily, she wants a prescription for MHT. How do you prescribe? What is the prescription protocol for this lady? What is the protocol you have? And for this lady of 51 years, just 1 year menopause, no symptoms, what is that she is keen on taking it? How do you prescribe her? Okay. Yes.
It is always an individualized prescription.
Yeah. Okay. I don't know how you people have divided it. Okay. Okay. Go ahead.
Yeah.
Yes, ma'am.
Yeah. So she always, it is an individualized prescription, ma'am.
Wonderful.
Depending-
That's a wonderful statement.
Yeah.
Yes.
Yeah, it should not be generalized. And at the same time, we have to tell her the risks and benefits and then the route of administration of drug
Okay.
and dose.
Yeah.
So is it low dose or ultra dose? So depending on that, we have to give them. That is how we will take decision.
Okay. So there are two types, no? Sequential and continuous. Sequential
Yes,
or a continuous therapy, is it not?
Yes,
So it
ma'am.
depends on the woman. If she wants to have a period, you give sequential.
Yes.
Okay, give the estrogen and the last 10 days give the progesterone and stop it, then she'll have a withdrawal bleeding. If a woman has attained already menopause, who never would like to have a bleeding again, she doesn't want to see, in them you give a combined continuous MHT.
Yes. If the woman did not have uterus, then we will give only estrogen.
Doesn't bleed. That is, we must ask her whether you would like to have monthly period. Yes, if it is a menopausal transition, they would like to have. That woman probably continues sequential therapy and then stop it and then get the withdrawal bleeding is okay.
Yes.
Or if they don't want, either you could use continuous sequential, that is give estrogen, last 10 days progesterone, again start estrogen without a break also you can give, or we can give continuous. And in women who doesn't have a uterus, you can give just a estrogen therapy continuously. Okay, that's the way we give. And always think that we will start with the lowest dose. We have most of the things. See, what we used to give in those days is conjugate equine estrogen. That's all. We had it and we used to use it. 0.625 milligram was the standard we used to give. Or a half dose I used to give, 0.325. But now we have a better drugs like a 17 beta estradiol is there. And then transdermal patches. We don't use usually transdermal for a specific people we use. Otherwise, oral is comfortable for all of them. So 17 beta estradiol or estradiol valerate are available. Now there is estetrol, E4 is available that is coming into the market, which is more useful than all these estrogens are available. We don't talk about it now because it is yet to come into the market. That is E4. We know E1, E2, E3,
Yes.
but estetrol has come. That is E4 has come. That's a synthetic again. That is going to be the drug of choice for MHT in future. Anyway, right now we use this drug. And please always give the minimum dose required. If she gets with the minimum dose, the symptoms are alleviated. That is enough. We don't need to increase the dose. That's the way we use. And then ethinyl estradiol and mestranol are not used for MHT. Natural estrogens are used. Of course, conjugate equine estrogen also you can use it as a choice, but most of us use now beta estradiol. Okay.
In natural
And
estrogens
has to be
also.
added. Wherever the uterus is in situ, add the progesterone, the one which does not have effect on the cardia and lipid profile.
Yes.
So the two such progesterones are, one is a micronized progesterone or dydrogesterone. So we choose, when progesterone has to be chosen, micronized or dydrogesterone, you use it.
200.
Okay. That's it. That is the way we have to do it. Okay. Duration and discontinuation of MHT. She is very happy. Okay, she has taken a prescription from you. She was about to go out. Then she has some doubt. So she comes, Madam, when do I start? Today itself I'll start? Or when you want me to start? She had the question. And how long I can take? She's going abroad. She says, can I take? How long I can take? She's asking. Okay. And then she says, if I don't want, can I stop abruptly? Okay. Yes.
Those for having symptoms, they can start, ma'am. But in this patient, for this to prevent osteoporosis, we are giving here for this patient, and she will take it. She can take for 90 days. Low dose, ma'am.
Okay.
And after 3 months, she can have a review.
After 3 months review is fine, but you want her to, after 3 months, you want her to stop, is it?
No, ma'am, no. But after 3 months, again, I want to review the dose and also the type,
That is good. Okay.
type of drug. Yeah.
Okay. Okay. That will come to. That will come to how do you follow them up? Will come to next question.
Any side effects of
So
that drug and
starting can
everything?
be any time you can start, is it?
Yes, ma'am. Yes, ma'am.
Okay, and the decision to stop should be
It should be
and
in
when
a
she
tapering
comes
manner.
back for the review, you see whether her symptoms are alleviated or she has
Yes.
got some side effects. Then
Yes.
you may have to say you
Yes.
stop it because of the side effects. So that
Yes.
depends on that.
But abrupt stopping should not be there. She needs to taper.
Yeah.
Otherwise, there will be reversal of symptoms.
Yeah, they that symptoms may come back and she'll be miserable with that. So abruptly should not stop and she can stop slowly that. Okay. She is on MHT continuous therapy. After 3 months, she had spotting for 2 days. She's anxious and seeks medical help. She has come to you now. Okay, as you said, she wanted to come, but meanwhile, she has got a little spotting. Okay, when should she come for follow-up and what? Now, this lady, what do you?
For this lady also, we will review her at 3 months and we will
She
see
has
that.
come now after 3 months with a spotting.
Yes, ma'am.
Now,
And
what
we
is
do the
that?
gynecological examination for this patient, ma'am.
Okay.
And all BP and everything history again we will review. All the evaluating blood tests we will do, ma'am.
So she is anxious now. What will you tell her?
Because of the therapy, she is having this spotting. I will counsel her regarding this.
Yeah, when you start the therapy initially, for few months they can have in between a spotting. You must tell her, or she would have by that time she would have lost. I mean, missed one tablet. You must tell them that if you miss the tablet, you are likely to spot.
Yes.
So those things we have to tell them, and then now they take the history whether she's continuously taking or there was a break. Why the spotting? Then look at the cervix. Okay, do the pelvic examination. Yes, of course, you can assure her initially they will have. Yes, once after 3 months, sorry, after 3 months, now later, when do you call her for checkup?
After 1 year, ma'am.
Yes, every
1
year.
year for breast examination and gynec examination.
Yes,
And
yes.
BP and weight management.
Yeah.
And also after once in 3 years, we will advise pap smear for her, ma'am.
Yeah, that is regular what is given to everybody should be followed. Not any extra this one. I mean, a shorter duration. We don't need to repeat the cervical cytology or mammography. They can come as it is a protocol for every woman. Okay, that's it. Now, 50-year-old has TAH, I mean, abdominal hysterectomy at 30th year of age. She does not know about her ovaries. Consulted many general practitioners for bothersome frequent urinary disturbances since 5 to 6 years and used many antibiotics. How do you approach her? Does she need vaginal swab examination? Role of MHT and probiotics in her. Who is going to take up this?
Madam, for this lady, to know the status of ovaries, the easiest way to know the status of ovaries is to by doing ultrasound, which is the primarily we rely on that.
Okay.
In ultrasound, we can see whether ovaries are visualized or not. After, if the ovaries are not visual, even we can go with the blood tests like FSH and LH, which will be elevated in surgical menopause. FSH is more than LH, elevation will be there.
Okay.
And for lower urinary tract evaluation, we will go with urine examination and urine culture sensitivity. These are the things we do to rule out the urinary tract infection. And for these ladies, UTIs are commonly anticipated because of the loss of the urinary tract tissue integrity, because of the loss of the estrogens, which impacts the vaginal and
actually, no, we don't know whether she is really loss of estrogen
yeah.
or it is only recurrent urinary tract infection. Is it not? So we don't know about that exactly. So what we need to do is if the ovaries are okay, FSH is normal. So we think of the local causes rather than menopausal causes. Is it not?
Yes, madam.
So yes, if suppose it's a urinary tract infection alone, what you need to do is
If it is urinary tract infection alone, we will go with routine urine culture, routine urine examination and urine cultural sensitivity, and treating with appropriate antibiotics will be sufficient for this lady.
no, she has been taking for the last 3 to 4 years the antibiotics. So it must be a recurrent complicated UTI. Now the upper tract evaluation is needed in such patients. Matlab kidneys and the ureters we have to look at. Kidneys we have to look at it. There is any problem in that. Pyelonephritis is one thing which can cause these problems actually. So we have to go up to see. Once it is not a menopausal, we know, then we have to go up and see the upper urinary tract. If she doesn't have, then probably we may have to take a urologist opinion or a nephrologist opinion there. Because for the last 5 years, she has been taking antibiotic almost, I'm sure she would have been resistant to all antibiotic. One thing at this juncture, what I want to tell you is, if you want to give antibiotic for a urinary symptoms, please, without doing culture, don't give antibiotic. You can give an antiseptic, urinary antiseptics, that Urispas is there, fluvoxamate. That you can use in tons. We have no problem. But once you start antibiotic, organisms are becoming very, very resistant to the urinary tract, especially organisms, E. coli and Pseudomonas and Proteus are becoming resistant to almost all antibiotics. We don't have anything in our hand if we repeatedly and indiscriminately antibiotic for this. I mean, here I just want to bring in that aspect of it, because just like that, she comes with a burning micturition, we'll give 3 days antibiotic. Now what she says, next time when she has got, she take the same Norflox, and now all the quinolones are resistant. So please remember. Okay, if suppose our FSH is high, now what do we do? She comes under genitourinary
syndrome.
Then it is easy for us to treat, because local estrogen is, in such cases, please remember, local estrogen is much better than the systemic
estrogen.
Yeah, systemic therapy. Good, ma'am. Very well, you brought out the this one. Now, what about the role of probiotics in these cases? She has repeated urinary tract infection. Is there a role for probiotics?
Yes, madam. There is definite role for probiotics because of the loss of the integrity of vaginal tissue, there will be alteration in the vaginal flora, decrease in the lactobacillus species, and increase in other pathogen bacteria. So the probiotics, which are especially with high doses of lactobacillus species, is required for this type of women.
Yeah, very good, very good. So probiotics we can add in all these recurrent cases or chronic cases. We can add probiotics and keep the vaginal pH low. That is important where lactobacillus will be there. Wonderful. Okay, now next situation we'll go. 57-year-old attained menopause 8 years ago with a BMI of 26 and complaints of unnatural pain in the both knee joint. This has become a very common thing among our women. How do you approach her problem? She just comes and says, I have a knee pain.
Yes, ma'am.
She's menopausal 8 years back.
Good evening, ma'am.
Good evening.
Actually, good evening, ma'am. I'm Nivedita, ma'am. Actually, she's complaining of only knee joint pains, ma'am. Just I want to ask her whether she has other symptoms like vasomotor symptoms, vaginal dryness, ala emanna unda ani adugutanu, madam. And also whether arthritis is, knee joint pains are attributing to the menopause, or else menopause is precipitating the pre-lying conditions. I just want to ask her, ma'am, like family history of arthritis and type of arthritis also, whether she's having pain associated with the fever or early morning stiffness, whether it's related to the rheumatoid arthritis or it's a general osteoarthritis or like osteoporosis or osteopenia, madam. Because in rheumatoid arthritis and all, if we give hormonal therapy, it may attribute to the increase in the pain, morning stiffness, increase of it. So I want to just ask her whether what symptoms she is having associated with the knee joint pains. So, and also after assessing her history and the risk factors and also clinical condition, I'll just counsel her, and her BMI is on the higher level, ma'am. She's overweight when compared to her BMI. So I'll ask her to reduce her weight, lifestyle modification, and also dietary intake of calcium should be increased along with the pharmacotherapy, general pharmacotherapy like calcium supplements, vitamin D supplements can be given instead of going directly to the hormonal therapy. Even if she is complaining after this also, then we can explain the risks and benefits, madam. Based on that, we can counsel her. It's a decision of the patient, madam, finally.
Very good. So, if it is osteoarthritis, it's proved to be osteoarthritis, you send them to either orthopedician. Okay.
Yes, ma'am.
Take care of her. If you think that it is not osteoarthritis, probably MHT will help. So, surely you said that distinction should be there, because
yes, ma'am,
it will be aggravated by MHT. So, we are thoroughly hasten to give the MHT. Good.
Yes.
Now the situation is 39-year-old presents with a delayed cycle for 6 months and she has got a vasomotor symptoms. Her BMI is 32, underwent Fothergill surgery at the age of 30, on treatment for rheumatoid arthritis, that is methotrexate, for the last 2 years, diabetes since 1 year. Her maternal aunt had a breast cancer. And of course, USJ pelvis has been done. Her endometrium is not very thick, it's only 4 millimeters. How do you evaluate her? She has come with a vasomotor. Mainly, she has come with a vasomotor symptoms. Now, how do we tackle her problem and how do we help her? Poor thing. She has got so many things.
Yes, ma'am.
Yes.
Ma'am, here the woman is 39-year-old and with complaints of amenorrhea and vasomotor symptoms, ma'am.
Mhm.
And ultrasound, the report she got is also showing ET of 4 madam, endometrial thickness. This looks for me like a menopausal transition, woman.
Good.
But I'm also thinking that she is also experiencing premature menopause because it is happening at 39 years old, because she is just 39-year old.
Mm.
So and also she has many other things like diabetes, and she is a rheumatoid arthritic patient on methotrexate and has a family history of breast cancer. In this case, I would like to proceed with a multidisciplinary approach, madam, in which counseling will play the crucial role, madam, because we have to tell all the facets, all the aspects of her problem, madam.
Yeah.
So I would,
You have to tell her then.
yes, ma'am. Then I will also discuss her family history in relation to for each other issue she has. I will discuss about her family history and at the age at which her maternal aunt got the breast cancer
Very good.
and what type of cancer was it. I will ask about that, ma'am. And then I will also ask her to go for early screening with mammograms and the regular follow-ups, ma'am.
Yeah.
And
So she has come for. Do you give her the? She has got vasomotor symptoms.
yes, ma'am.
Are you going to give her MHT?
Madam, I am little skeptical here, madam, because already there is a history of breast cancer in the family. And so
She has got something is rheumatoid arthritis which can get aggravated.
Yes, ma'am.
Yes, family history of breast cancer, when you do BRCA 1 and 2,
yes,
if
ma'am.
suppose that person was BRCA 1 and 2 negative,
Yes, ma'am.
then her chance of having a breast cancer will become very less.
Very less.
So right away we cannot say no to her because she is suffering. So suppose genetic counseling and her aunt's BRCA 1 and 2 is available for us, the report. If she is negative and it's only a sporadic case, then we have no problem because it cannot be running in the family. Okay. And then probably only thing we have left is rheumatoid arthritis here, because diabetes, as we see the next slide, diabetes will get improved when you give the hormone therapy. There is an improvement in the diabetic control and insulin sensitivity will increase. I'll show the slide. So here what we need to do is, because of this, we are hesitant because previously earlier we discussed about it, it will increase. So probably if the severe symptoms are there, we may have to give other like SERMs we can give, or selective serotonin uptake inhibitors, SSRIs, can be given now.
Yes, ma'am.
Okay. That's it. Bone health and calcium, vitamin D, weight bearing, as you said, she has to reduce the weight.
Right, because
Now, other things we can use for the bone is biphosphonates. You can give biphosphonates. Okay.
yes, sir.
Okay, that's it. Now, the usefulness of the diabetic woman. Diabetic and MHT, we think that diabetes is a contraindication. No, potential benefits of MHT for women with diabetes are there. It reduces the diabetic risk, improve the glycemic control, and it improves the insulin sensitivity in all of them. So diabetes is not a contraindication, but we can use it in diabetics if there is necessity, so that even diabetic control will improve. That's it. Okay. Now 50-year-old underwent mastectomy and chemotherapy for breast cancer at the age of 35. Presented with 1 year of amenorrhea. Now, we don't know her ovarian status here. Usually, PR positive, usually oophorectomy is also being done, but here we don't know her oophorectomy is done or she has got a ovaries in situ. 1 year of amenorrhea she has got now. The complaints of burning, micturition, and vaginal dryness. Her BMI is 40. What are the management options we have for this lady? BMI is high. Previous history of she has been treated for breast cancer and chemotherapy has been done. And then now she is amenorrheic. Yeah.
Madam, her BMI is too high, which is indicating more than 40. And she underwent chemotherapy also. Lifestyle. So we definitely advise her personal physical activity and lifestyle changes to decrease her weight. And for other symptoms like vaginal dryness, we advise symptomatic management for those things to improve the vaginal dryness and to improve the vaginal discomfort. For her, local ointments or local creams with local estrogen therapy may be needed for her.
Yeah.
Main thing is it is an disciplinary approach involving all the team, not only the gynecologist is required for her, madam.
Yeah.
And yes, ma'am.
Okay. So we have to ask the oncologist. We usually have a dialogue with them. Patient has come with severe vaso. Suppose she has come with the local symptoms of vaginal, we are easy to treat her because local estrogen can be given, or other lubricants or something can be, or even a laser. Now they are doing laser for the vaginal dryness. Very effective, I believe. Okay. Here in Bangalore, they do regularly. So those things can be done. Suppose if she has come with a vasomotor symptoms, now you must have a dialogue with the oncologist who is treating her and ask them whether is it okay to give for a very short time estrogen, or we can go for SEMS, whether we can give SEMS. So that we have to ask them and then decide about it. Well done. Okay, ma'am. 39-year-old diagnosed with a CA ovary stage 1B after diagnostic laparoscopy during infertility workup. Frozen section and analysis revealed grade 2 clear cell carcinoma of the ovary. Underwent, of course, the treatment she has gone through. Definite treatment has been done. Post-operative chemotherapy also has been done. BMI is 25, lipid profile is triglycerides are increased. She is on therapy for treatment on hypertension since 1 year. She attends a menopause clinic. How do you approach her?
Yes, ma'am. Good evening, ma'am. Actually, she is a 39-year-old patient who has undergone who had surgical menopause because of the treatment EAS and BHO because of the clear cell carcinoma. But we don't know whether she has symptoms or not, madam. And she is also belonging to high risk group because of clear cell carcinoma. And
No, you are not audible. You are muted. Unmute yourself, ma'am.
okay, sorry, ma'am. She's a 39-year-old who had
That we could hear. That we hear. Whether symptoms are there or not.
whether symptomatic or not, we should evaluate, ma'am. And also, she belongs to high risk group because it's a clear cell carcinoma, and also she has a hypertension which is on for which she is on treatment, and also she has elevated triglycerides levels. Altogether, she belongs to the high risk group. So we should see whether its MHD is necessary for her, and also you should counsel her about the risk of all this venous thromboembolism and the recurrence or the occurrence of the breast cancer in her. And according to me, I don't recommend MHD until and unless she is symptomatic, or else we can go for the local therapies if she has any mild symptoms like vaginal dryness, as you said, laser therapy, or else calcium supplements, biphosphonates for the bony pains or all. So generally, it's not recommended, but if she had symptoms, we can go for mild local therapies also, ma'am.
Very good. Other therapies we can use, but that carcinoma increases the chance of VTE,
Yes.
and also the recurrence chances are high with the clear cell carcinoma.
Yes, ma'am.
Full carcinomas is even endometrium and the ovary clear cell carcinomas are very, very high risk and very aggressive tumors they are, unfortunately. So, rightly said, no MHT for her. Only other therapies we have to give.
Yes. Thank you.
Now, 48 years, attained menopause 2 years ago. She's a beautician by occupation. Naturally, she wants to be beautiful. She is growing more coarse hair and upper lip and chin since 2 years. Gained more weight and BMI is now 39. How do we address her problem? She has come to you as a gynecologist first. So how do you address? Yeah.
She is a postmenopausal woman, madam, but she is showing symptoms more of androgenic excess, madam. That is, she has hirsutism. So I would like to evaluate her properly by knowing whether any other androgenic features like acne, deepening of voice, male pattern baldness is there. And then I would like to know the cause, ma'am, like any androgen secreting tumors, whether she has, or adrenal tumors, which will increase the levels of androgens.
Good.
And also I will address her obesity because she is falling under class 2 obesity, madam, because her BMI is around 39.
Yeah.
So I would like her to also advise her lifestyle modifications and weight loss. And here I would MHT. I don't know, madam, because if at all an androgen secreting tumor is there, MHT will only help with adrenal androgen secreting tumors, but it will not help with ovarian secreting tumors, ma'am. It may worsen the scenario.
Yeah.
So we'd like to proceed according to the whatever is the
There are
outcome.
androgen secreting tumors, you remove that, immediately everything will come down. We had cases, okay? All the symptoms and even hirsutism, maybe what is their hair growth, that cannot be done, that for that cosmetic therapy she has to do. Otherwise, the growth will stop. If it is androgen secreting tumor, either in the ovary or in the adrenal, we have to do the surgical excision of that tumor, then it will be okay. But I mean, here the slide says that just blindly we should not go thinking that it is menopause.
Menopause.
It comes with the androgen, hirsutism as a main thing. We have to at least one scan we do where we know adrenal tumor or the ovarian tumors are there. We pick up, then probably we do the male hormone estimation. That will confirm our diagnosis. Good. Very good. Now, 60-year-old comes with the night sweats, urinary frequency, urgency, joint pains, and backache. She had undergone CABG and for the cardiac reason 2 years ago. Coronary artery disease 2 years ago. And was on MHT. Before surgery, she was on MHT. Now she wants to restart MHT. What's your advice to her?
Excuse me, ma'am. This is a case with previous history of coronary artery disease, ma'am.
Yes.
So she is very high risk for again getting CAD. So in these cases, better not to give MHT, ma'am. We have to avoid MHT in these cases.
Yeah.
So the other drugs available are selective serotonin inhibitors or selective serotonin norepinephrine reuptake inhibitors or gabapentin or clonidine. They can be tried, but MHT should not give.
So this is one place where all of us will affirmatively say no MHT to you. Is it not?
Yes, ma'am.
No dilly-dallying here. Wonderful.
Yes.
So this is the assessment of the risk. This is beautifully given. See, high risk,
Yes,
avoid MHT.
Yes.
Okay. High risk category, or these are the women who can have the high risk category. These are the history. And then the definite risk, but caution with MHT. Okay.
Yes.
This is the definite risk is there. Known diabetes, smoking, uncontrolled hypertension, obesity, sedentary life. All these women comes under the yellow zone. Now the low risk women, definitely they can have the MHT. The risk categorization according to this is, scoring is low risk is less than 5, intermediate risk is 5 to 7.4, high risk is 7.5 and above. But now what we have is, what we use in the menopausal society is Framingham risk scoring. Okay, Framingham risk scoring is, you have a big chart there, yellow, green and red. I don't want to confuse you with the chart. It will take a long time for us to understand that this is simple. High risk is more than 20%. Intermediate risk is 10 to 19 and low risk is less than 10. Now, this is the considered treatment in all cases. High risk cases, treatment of the other causes, whatever she has got, we have to give for her. Okay. And these are the things which are there to give alternate drugs. What we can give is for the, LDL will be high, HDL will be low in all of them. So those are the therapies we have to give. This chart you may not be able to understand, but the chart, a big chart is there. The age is given and the zone is given. Depending on this factor, there are factors, age, under diabetes, hypertension, family history, hypertriglyceridemia, all that is there with the age. And then whether you come into the green zone, yellow zone or a red zone. Depending on that, the risk for the coronary artery disease is estimated. If we come from Framingham risk score, and if we come to the intermediate or high risk score, definitely there is no MHT for those women. Women who have the low risk, they can have MHT with caution, with a regular follow-up. That's it. So we have to, all of us must get familiar with the Framingham risk scoring. Now, there's no paucity of time. I cannot go through that now. It's an elaborate chart is there. If once we need, we will discuss separately. Now the next situation is 45-year-old attained menopause 1 year back. Want to take MHT for protecting her bones. On evaluation, she was found to have a dyslipidemia. High triglycerides and LDL levels are high. And then no diabetes, hypertension or any other medical problems. Her BMI is 26. She has familial dyslipidemia. Matlab, all the members in the family have dyslipidemia. Such people have a high risk for coronary artery disease. What is your advice for her? Yes. Yes, any one of you. I think these are the additional questions I have put it. If you, any one of you take up and answer. Yes, we have discussed everything, but each one I am taking dyslipidemia and MHT, so that we will definitely tell the audience without any confusion what we are supposed.
We should not give MHT, ma'am, because she's having hyperlipidemia.
Good. Okay.
And here we can use not oral, but we can give transdermal
Yes.
MHT, ma'am.
Yeah, you can give a transdermal if it is needed. And then the tibolone is
is a safer choice.
With the triglyceridemia, tibolone, and especially when I said familial triglyceridemia, it runs in the families. Even I've seen a young lady is about 30, 32 years having a MI, myocardial infarction. She was pregnant. Her husband was 30, 32 years. He had a myocardial infarction. Then we got when she was pregnant, I got her triglyceride level. It was a sky high, 400. Even one girl recently we delivered her. Her triglycerides was 450. Then I sent her to endocrinologist and I said this will be the familial triglycerides. She was 25 years. Triglyceridemia, so very high risk for thromboembolism. So we had to heparinize her postpartum. And then we started an aspirin during pregnancy. Then in such people, there is no question of MHT. Yes. If they have symptoms, probably we may go in for Tibola. Okay, that's it. Now the next thing is 51-year attained menopause 1 year back. She wants to take MHT for the protection of her bones as she attended a webinar on that topic recently. She is hypertensive for the last 4 years on medication. BMI is 29, no other comorbidities. What do you advise her? She wants to take MHT for a bone protection.
I mean, here hypertension also increases with MHT, ma'am.
Yes.
So in this case, and at the same time, we can give here also, we can give transdermal estrogen for these patients, ma'am.
Yes.
Other than oral.
Neutral effect on BP and metabolic factor, as we spoke in the beginning itself.
Yes, ma'am.
We can give that if she wants, for the bone protection if she wants. See, we said that osteoporosis, we do the bone density. If her bone density is normal, probably what we can tell her is do the weight-bearing exercises, activity, and then take the calcium, vitamin D, and look after your bones. Okay, regular weight-bearing exercises will slow down the osteoporosis. But
and
if
lifestyle modification,
then we may have to give the transdermal estrogen with oral progestogens, which has again no effect on BP and metabolic factors. Good. Okay. Now, 46-year-old anxious woman, asymptomatic, whose mother had Alzheimer's disease. She wants to know whether MHT can prevent her Alzheimer's disease. What's your advice for her?
Already Alzheimer's is there. Here also
her mother, she has got Alzheimer's, her mother has got. She doesn't have. So she wants to prevent Alzheimer's by taking MHT. Is it advisable?
Ma'am, once again, case scenario, ma'am, age of the patient.
Sorry. What
46.
is
Okay.
She is asymptomatic, not attained menopause, but her mother had Alzheimer's, so she wants to know whether she can take MHT to prevent Alzheimer's.
Prevention of Alzheimer's, MHT is not recommended, ma'am.
Yes.
And she's only 46 years, but in menopause, the Alzheimer's may come very late now, ma'am. So after 60 years like that, so we have to give her cognition exercises and brain activating exercises.
Yes.
We have to counsel her regarding
Cognitive training therapy
and positive attitude, everything we need to advise her.
Meditation and the breathing exercises.
Yes.
Okay. These things will help them to reduce their prevalence of or chance of Alzheimer's in them. Rather than preventing Alzheimer's, MHT is not recommended now. Even when they have Alzheimer's also, it is not. Now it is proved that cardiovascular protection and Alzheimer's protection is no more there with the MHT given prophylactically. Is it not? Even when there is disease, it will not reduce the disease prevalence. Okay, that's it. Okay. Now, 51-year-old on continuous transdermal estrogen plus natural progestogens for a VMS. She attained menopause 2 years back, comes with intermittent spotting for 4 months. Her BMI is 30 with no other risk factors. How to evaluate and treat her? Intermittent spotting for 4 months, and she is 51 years on continuous estrogen and progesterone. Whether she attained menopause? Yeah.
She is. So here it may be because of MHT, ma'am, here also because of continuous release of estrogen. And at the same time, we need to evaluate her because there is maybe possibility of any hyperestrogenic condition causing endometrial hyperplasia and all those things. So we need to do ultrasound pelvis, and we have to see endometrial thickness also. And we have to counsel after doing investigations. We have to counsel her. It is because of MHT she is getting intermittent spotting, or it is because of the disease? Any effect on the endometrium she is having intermittent spotting? We have to counsel her, ma'am.
Okay, so you have to rule out the fibroid. Polyps are the ones which can cause in the postmenopausal woman. The bleeding is most common cause is polyps. Now, when she is on hormonal therapy, she can as well have a polyps. Okay, when the progesterone is given, it should not happen, but sometimes it can happen if our weight is more. So, so we have to rule out all these possibilities here before we step up the dose of MHT, because this must be breakthrough bleeding. So we may have to give a slightly more dose once you are sure that there is no other pathology here. Okay. Yes, ma'am. So wonderful it is. At the end, what do we say? Each one of you, what do you want to say? One sentence. If we are allowed. Are we allowed? 1 more 5 minutes is there for us?
Yes, madam.
Because our panelists have done a wonderful job. So I wanted to give them the last word. From each one of them, I want to hear the last word. Yeah. What do they want to say? Yes, ma'am. Each one of you, quickly, one sentence about this MHT and menopause.
MHT is personalized, ma'am. It's not generalized.
Good. Very good. Next. Sweta.
Proper evaluation.
Proper evaluation is needed before you give MHT.
Start the MHT, ma'am.
Okay.
And learn to know that there are so many ifs and buts, ma'am. We have to know and carefully assess the patient and personalize the MHT for the patient.
Wonderful. Next, anybody? Yeah. Anusha?
Ma'am, everything is tailor-made, ma'am, and look for other alternative if the patient doesn't fit into MHT.
Very good. Very good. Mobeen? Idara, Mobeen Raj. Hemantamani?
Ma'am.
Your last sentence for the audience.
Careful analysis and proper treatment of the patient is required.
Okay. That's it.
Ruling out all comorbidities.
Amma?
After ruling out all comorbidities, we have to specifically use the MHT and very carefully follow up the patient.
Very good. All of you said everything. I don't need to say. MHT and menopause is highly controversial topic. It's not recommended to all women who attain menopause. Main indications are vasomotor symptoms, genitourinary and osteoporosis. Risk is high and benefits is less when started after 60 years or more than 10 years after menopause. Individual therapy, as all of you said, is the recommended choice. Women with comorbidities and history of cancers have to have a detailed evaluation and counseling prior to prescribing MHT. A lot of gray zones in MHT practice. As we increase our knowledge about it and we start practicing, you become more and more seniors, then you will be able to handle it because a lot of gray zones are there. Careful assessment and judicious use of MHT gives maximum results. Thank you very much. Once again, I thank
We want to
all
thank
my panelists for a wonderful discussion, and they have really done a good job. I think all audience, if they are there still, they will agree with me that
Yes,
they have done a
madam.
wonderful job. And for the audience, thanks a lot. Maybe a little bit of boring it was for all of you, but bearing with us and be with us, all of you, thank you very much. And again, sincerely thank the organizers for giving me this opportunity to learn more and be with all of you youngsters in this evening. Thank you very much.
Thank you for your patient
you so much,
teaching, ma'am.
ma'am.
We are also benefited so much from your talk.
Thank you.
Sandhya madam. Sandhya madam. Okay. Madam,
Unmute, ma'am.
Yeah,
madam,
yeah,
am I
please.
audible now, madam?
Yeah, you are audible, ma'am.
Ma'am, mute
Yes,
lo
madam.
unnaru.
Yes, madam. It was a wonderful session, madam. Actually, Sandhya madam wanted to join the session, but somehow she was busy, I think, with patients. On behalf of her, I would like to thank for this session, and I would like to thank all the panel members and Dr. Jyoti Suchitra madam and Dr. Nagajyoti madam for the very nice introduction, madam. And it's very nice to hear everything, everything, and still learn to more, and still there is a lot to know from you. If possible, we can have one more episode, madam.
Okay.
Thank you, madam.
Thank you very much. Thank you, all of you.
Thank you,
Okay.
ma'am.
Thank you so much, ma'am.
Bye, Jyoti.
Thank you, madam. Thank you very much.
Thank you.
Goodbye to all of you from us.
Have a good evening, all of you.
Good
Thank
evening,
you, ma'am.
madam. Bye, madam.
Shall I log out?
Yes, madam.
Thank you.
Thank you, madam.